Hey, welcome to the Go-To Physio podcast, the podcast that helps you get real-world results with real people while also helping you become the go-to therapist in your town. I hope you enjoy the show. Hey, you're very welcome to today's episode of the Go-To Physio podcast. My name is Dave O'Sullivan, and the aim of this podcast is to help you get real-world results with real patients to make meaningful impacts on their lives while also helping you become that go-to therapist in your town or build that profitable clinic. Now, if this is your first time listening, I highly recommend you go back, you listen to the first episode where this really lays the platform on what the Go-To Physio is all about, especially where I shared my business growth plan or even my business growth plan to become the top pro sport physio. Okay, so it doesn't matter whether you want to work in private practice or pro sport. What you'll find about me is that everything that we deliver in pro sport, we implement in my own private practice. Now, today what I want to talk about is the 12 steps that I use to get somebody from the initial assessment back to a successful discharge. Now, we've got an accompanying blog on go2physio.com. If you're a person that needs to visually see some of these concepts, then please visit my website, go2physio.com, where you'll find the accompanying blog to this podcast and also lots more information, free downloads, tips, and clinical content to help you build a profitable, long-lasting, scalable business. Now, today we're going to build on what we talked about last week. Now, if you remember last week, we talked about the 7 steps that I use to build a profitable private practice, or putting it another way, the 7 steps I'd use if I wanted to achieve my dream job in professional sport. Okay, so what we talked about in step 1 was having the confidence and clarity on the patient's problem, but also having the clarity on the solution, i.e. their step-by-step progressive graded exposure loading program. Now, what I want to talk about today is we're going to dive into step 1 now, and then we're going to actually dissect the different components that we need in order to have the confidence and clarity to find the true problem, and then also the solution, which will be that step-by-step plan. So just to quickly recap last week's show, step 1 was where we have confidence and clarity on the patient's problem, and then we have obviously clarity on the solution. That allows step 2, which allows us to effectively explain the problem and solution to the patient after the initial assessment, which allows the patient then, step 3, to have confidence and clarity on the actual plan that's in place, confidence in you as a therapist, but also clarity on what's going to happen. And in step 3, we talked about setting expectations for the patient, which we're going to touch again upon today. What that allows is step 4, patient adherence, buy into the treatment plan, and an ability to, or certainly improve your chances of that patient completing the treatment plan, especially when the pain eases. Which then that allows, from a profitable business point of view, you to increase your revenue due to your patients not dropping off, cancelling, not showing up, and also ethically, obviously, making sure that they finish the treatment plan. Which then allows you, step 6, to have a busy go-to clinic. And then obviously that allows you then step 7 to hire other therapists to help you as well as your demand grows, which then obviously at that point, these therapists then need to go back to step 1 and they too need that confidence and clarity. So what we're going to talk a lot about today is step 1, how to get that confidence and clarity. Now, you might have read my book, The Go-To Physio. Okay, so in that book, I outline the 12 steps in quite a bit more depth. So if you want to pick up the book to accompany this podcast, if you find this podcast useful, then please visit the go2physio.com/book and you'll be able to get the book there. And while stocks last, I also have a free accompanying DVD that's going with it if you purchase the book from my website. Now, in step 1, confidence and clarity on the problem and the solution. So how do we do that? Well, that's broke down into 12 kind of micro systems, if you will, that I use. Okay, so my 12 steps that we talk a lot about in my Return to Play course that I teach For my mentorship, whether it's upper limb, lower limb, lumbar spine, cervical spine, soft tissue injuries, you name it, we always follow this 12-step approach. Now, this 12-step approach is all part of your step one in gaining confidence and clarity. So the first component to this is making sense of the objective assessment, okay? Now, how we make sense of the objective assessment is, sorry, I'm going to go back a step. It's not making sense of the objective assessment, it's making sense of your patient's story, okay? So that you can make sense of the objective assessment. So I apologize, I skipped a step there. Step one is making sense of your patient's story and having confidence and clarity then to make sense of the objective assessment. So a lot of therapists, when I chat to them before they come on the mentorship, they'll say, you know, I just go through the motions with this objective assessment, you know, and I'm just telling them to touch their toes, backward bend, you know, and, you know, I'll come out of the objective assessment and then I'll just go straight into some treatment without a thought process. What my mentorship really encourages and promotes is that you put your pen down for a minute, you look your patient in the eye and you actually listen to your patient. And I'll always say a good subjective assessment is one in which that you can literally at the end of that session, if you've got 5 minutes to write your notes, that you can literally write the subjective assessment down. Because what that means is that you've processed that information. What I find a lot of therapists, especially therapists who including ones that, you know, have come from the national healthcare setting and come to work in my private practice, and not just that, but other therapists who've worked in private practices, when they come in and we do training with them and we go through the subjective assessment, it's all head down, writing, okay? Now, if you're head down, writing, it's very hard to process that information, okay? Now, I appreciate that when you write something down, that's gonna help you process, but what I'm talking about is starting to put the pieces of the puzzle together, okay? So having a step back. Now, every question that you ask your patient has to have value to you. There has to be a reason why you're asking it rather than just beating off the subjective assessment questions that we learned in university. So we're going to talk a little bit about motor adaptations later, but what I do in the subjective assessment is every previous injury that person is telling me about. So again, what I want is a chronological order of their injury history. And every injury that they're telling me about, my question in my mind is, right, how has this injury potentially affected that person's movement strategy that may have potentially overloaded or caused the area of their body that they have pain now to become maybe a little bit grumpy, sensitized, have a pain experience, whatever terminology you want to use. So that's the first big thing with the subjective assessment, because we know that stress precedes pain, okay? The literature now is starting to emerge that it's not just a case of, well, if you've had a previous injury or that predisposes you to the likelihood of having a future injury in this area, but actually if you've had a subsequent lower limb injury, that's associated with an increased risk of having a new injury on that limb. Okay, now from clinical experience, it can be where you may have had an injury on this side, and then next thing you have an injury above or below it. But also from my experience, that can it's not just that side. Okay, now what we know from the motor adaptation research is that no two people react the same to pain. Okay, that everybody's response is individualized. How we manage a noxious stimulus or how we manage a pain experience is very individualized to us, which makes sense when you look at our previous injuries or our previous stories. So the big thing I'm looking for is the chronological order in the injury history. I want to know, if there's anything here that could potentially impact the area where they come in now with this pain experience. Hey, I hope you're enjoying today's show. For more clinical content and tips to help you implement this content in the real world, please visit Go-To Physio.com for more information, including my 6-step patient adherence checklist, which you can download for free. And also there's more blog content that helps you implement this stuff in the real world. You'll also find links to my YouTube show, the Go-To Physio Show, as well as lots of more information to help you become the go-to therapist, helping real patients get real results in the real world. If there's not a massive injury history, then I'm looking for any significant changes in their life, any traumas, any times of increased stress. And again, that becomes very important for us when we appreciate the role of the pelvic floor and diaphragm and the impact that they can have on the musculoskeletal system as a reaction to a sensitized respiratory system. Okay, so if I'm stressed, the easiest way to think about this is anxiety. You think someone having a panic attack or with anxiety, their breathing rate's going to be very, very fast. Okay, if your breathing rate increases, your range of movement to your diaphragm is decreasing. Your range of movement to your diaphragm decreases, the range of movement to your pelvic floor decreases. That has a big, big impact on our hip flexion, on our shoulder range of movement. Okay, our rib cage position affects our pelvis position, which can have a big, big impact on the peripheral tissues, the length-tension relationship. So, for me, everything affects everything else. And really, at the end of that subjective assessment, you should have a good idea, rather than sticking our elbows in the glutes, and the glutes aren't firing in inverted commas, is this all what we're seeing in the objective assessment, a reaction to that person's setup as a reaction to their individual stress? Okay, so we should have some idea or some working hypothesis after the subjective assessment. Now, I'm not saying for a second don't ask red flag questions, your yellow flag questions, any kind of, the foundations. You still want to have an idea of that, but I'm more interested in understanding the person's story rather than getting a 24-hour pattern in a VAS, okay? Now, okay, you can still get them, but at the end of that subjective assessment, you should have a pretty good understanding of that person's story. So that brings us on then to the next step, step 2, which is making sense of the objective assessment. So when I see someone touch their toes and they bend that knee, or maybe they're a little bit stiff in their rib cage, or we ask them to rotate or twist and they're not loading their lateral heel when they twist, then I'm asking myself, okay, what's in their story that may be causing a perceived threat or protection of loading the tissues here? Because when I ask you to rotate to your right, I'm gonna want you to shift some of your weight onto your outside of your heel. Think of a backswing in golf, okay? We want to get some load, not all of it, but we want to get some load onto that outside heel. When we get some load onto that outside heel, your fib, your tib, they're gonna ER, okay? Which is gonna lengthen your ATFL, okay? So again, if I've got an all ankle injury and my brain's still protecting this area somewhat, okay, maybe it doesn't want to lengthen these tissues, okay? Just again, working hypothesis. So is that maybe why I'm, when I twist to my right, I get back pain? Okay, has that got to do with that previous injury? Now, this is just hypothetical here. As I said, you need to make sense to your patient. So everyone that gets back pain when they twist, I'm not saying it's going to be their ankle. I wish it was that simple. Okay, so that's how it allows me to make sense of the objective assessment. Okay, if someone goes to touch their toes and they get back pain straight away, okay, and they're kind of leading, they go to touch their toes or they feel tight in their hamstrings and you can see that their back is extended as they go to touch their toes, then that to me is just that their rib cage isn't depressing. The first tissues that want to lengthen as we depress a rib cage is our diaphragm. Okay, so now if that person's had a massive time of stress, they're getting a lot of back pain, they're not sleeping well, okay, they go to touch their toes and they use this kind of extension-based pattern, okay, very little depression in the rib cage. Then rather than, massaging the lumbar spine, mobilizing the facets, would my time better be spent, restoring an ability of that diaphragm to go through a full range of motion, desensitize the receptors in the respiratory system so that we can decrease our breathing rate. Okay, we decrease our breathing rate, we increase the range of motion through the diaphragm via a prolonged exhalation. Okay, so the longer we exhale, the more the diaphragm's going to have an opportunity to lengthen. Okay, so there's clues everywhere with our movement. Okay, but again, we always want to relate that back to our subjective history, or better still, that person's story. So then, what I'll do then is step 3 is I'll put them on the bed and I'll use a passive assessment. And again, the passive assessment can tell you a lot, okay? So if someone's got a restriction in hip extension and there was this maybe traumatic scenario, this person had a sensitized respiratory system, if that person's going to pinch in their groin or they've got a restriction in hip flexion, internal rotation, what I might do then is I might get that person to forcefully exhale, okay, or prolong their exhalation, or help them depress the rib cage, and then recheck hip flexion. If hip flexion's improved, then I've got my working hypothesis that actually, you know what, if I can get that diaphragm and pelvic floor to start moving, all of a sudden this hip flexion internal rotation range is going to be a lot better. So then that might help me, rather than stick my elbow in the glutes, it may be a better use of my time to desensitize the respiratory system to help that person's peripheral tissues. Okay, so I hope you can see where, you know, there's the clinical reasoning of the whole person, and not just the musculoskeletal system, can be very, very valuable, because it can save me wasting time. You know, we stick our elbows in the glutes, they feel good initially, but then, you know, 5 minutes later, they're tight again by the time they've got down to the car park. Yeah, if there's a decreased hip internal rotation in supine versus prone, there's different tissues that are going to have to shorten and lengthen. So again, rather than just sticking my elbow in the glutes, I can clinically reason where it may be best to start desensitizing. Okay, step 4, I want to put a submaximal load. Okay, so for me, with my lower limb, I put 8. I put a load tolerance test, if you want to call it that, a submaximal muscle test, whatever you want to call it. The key is submaximal. Okay, I just want some baseline load tolerance through 8 different directions while they're on the bed. I'm looking to see if they can work under isometric-like conditions. But not only that, I want everything to work together. So again, if I'm checking hip extension, I want to initiate that movement through intent through the foot. Okay, so again, you might have seen some of my blog posts. The glute is, for the vast majority of tasks, is only going to be as successful as the hamstring and the gastro allows. Okay, and we'll have a separate podcast on that. Okay, if the hamstring and gastro aren't doing their job and the knee extends, then the knee is going to do a lot more work than the hip as our body weight travels forward. Okay, so I'll put 8 directions in that, and then what that usually gives me is 1 or 2 directions where there's a perceived threat, where they can't tolerate loading through these directions. So if I'm side lying and I'm doing a hip abduction test, first thing I want to do is I want to be pushing through that, maybe that 5th metatarsal or something like that. When they do that, then they have to evert, which is going to get the peroneals working with their glute med, with their VL, with their QL, with their intercostals. Everything has to work together. So I'm interested in how they're coordinating that movement. So by the end of my objective assessment, I've got my information of peripheral tissues that are contributing to the pain experience, okay, which I would focus 20% of my time with, the symptoms, and then 80% of my time and my attention is on what I would call a true stressor. So what directions aren't doing their job, that's maybe causing other parts of the body to overload. Okay, so what I'm going to do then is I would settle down the symptoms, obviously, but before I do that, I go to step 5, which is the effective explanation. So this is kind of now where we're starting to get into step 2 a little bit. Okay, so again, if we've clarity on the problem and solution, that allows us then to effectively explain the problem and the solution, i.e. the treatment plan, to the patient. Okay, so if we can get complete clarity ourselves on what needs to happen, then you know yourself, your physiology, your confidence changes in how you speak to your patient. How you speak to your patient, okay, with confidence, is very, very important for your patient to have confidence in you as a therapist, to get buy-in, to get adherence to your exercises, to trust you. Okay, I think that stuff's very, very underappreciated. Okay, so hopefully you can see here where the ability to understand the subjective assessment, then take this and make sense of the objective assessment, is critical to then having an understanding, okay, here's my problem, here's my solution. So for me, the problem is that, let's say for instance, as that foot hits the floor, if we don't get a good co-contraction at the knee, we're going to probably start to see their knee flex a bit as their foot hits the floor. They'll kind of sink almost, okay? So that to me means that the quads are probably going to eccentrically load a little bit more. Hamstring and gastro in a shortened position, they're going to have to produce a lot more force to do the same amount of work, okay? So they're probably going to get more of an eccentric load through the knee. Where does that load have to go? Usually goes towards, most of it goes towards the tendon. Maybe that tendon's getting a bit irritated, a bit grumpy because it's doing a bit more work, because the gastro and the hamstring aren't co-contracting, which then isn't allowing the hip to do work either, because then if we come down, we have to come back up. So maybe the knee then is doing a lot more work than the hip as our body travels over the foot. So we're getting fake hip extension, so to speak. Okay, we're actually getting knee extension, which gives a passive hip extension. Okay, so you think as you're walking and your knee snaps back, okay, if my knee snaps back, I achieve hip extension, but I've done it through doing work at the knee, and my hip has pretty much passively done work there. Okay, so again, if we can delay knee extension, then that allows the hip to actually do work while the knee works isometrically through a core contraction. So proximal gastro, distal hamstrings, very, very important for that. Okay, so again, off track there, apologize. As you go through these episodes, you're going to see I do that sometimes. I apologize. So you can see the first 4 steps are critical for me to be able to effectively explain to my patient the problem, the solution, and the treatment plan. If we can get that in place, then that's going to give me a great chance of the person having clarity on what they need to do. But most importantly, it's going to allow me to set expectations. If I can set expectations in that initial assessment, that's very, very important. The nice formula that I love, that I saw somewhere, is expectations minus current reality equals level of happiness. And think about that, it's very, very important. Okay, if someone's expecting this pain to be gone in 1 or 2 sessions and then get back running, whereas actually the reality is, you know, it's going to probably take 8 sessions because they've had it for 6-7 years. Okay, if they're expected to be back in 2 and it's session 4 or 5 now, the expectation versus the reality, there's a big mismatch. So that patient's usually not going to be too happy. If we set expectations in the first session, which means for a lot of therapists sticking their neck on the line, okay, offering an actual prognosis of, look, this is the treatment plan, and you as a therapist have the confidence to say, right, this is the problem, this is the solution that I think is the best way forward for you, that's going to make a meaningful impacts to get you back to the outcome that you came in with. The outcome that the patient came in with isn't to get rid of the back pain usually, because the back pain's stopping them from doing something. They want to get back to that thing, that's the outcome. Okay, so this is the plan, this is how long I think it's going to take. Now, obviously, we'll probably put in our disclaimer there of, hey, you know, obviously everyone, you know, is a little bit different. We have to see in the first session or 2 how quickly you're responding, how quickly the pain goes away. Obviously, that's going to depend as well on how, you know, diligent you are doing your exercises and blah, blah, blah. Okay, so again, you can go into that. Okay, so what that does, that set expectations. Now, the first time you say that, there's going to be a big emotional reaction, probably, you know, if their expectations were a little bit different to what you're telling them the reality is. Okay, but for the vast majority of people, when they see the amount of work that needs to happen to get them safely back and have confidence, then most people will be, you know, quite understanding. Okay, and again, you have to explain this very logically. In my mentorship, I spend a whole module on effective explanation. It's that important. Communication skills are critical in my opinion. Okay, so that's the first 5 steps. I'm going to leave it there for this episode. That ties us in nicely then to the next episode, where I'm going to start to talk about hands-on treatment and then how we use our step-by-step system, and especially how we use our hands-on treatment to help us get to the next step of the graded exposure, rather than just using hands-on treatment as a standalone intervention. Okay, so that's it for today. I hope you enjoyed the show. Quick recap. Step 1 in the big business growth plan is to have confidence and clarity to explain the problem and solution treatment plan to the patient after the initial assessment. That's step 1 of our business growth plan. We dive into that step 1. There's 12 components to that, okay, of having that confidence and clarity. What we need, okay, is we need to have a systematic, logical, step-by-step program. But most importantly, the first thing we need is step 1. We need to understand the patient's story. Step 2, we need to be able to make sense of the objective assessment. Step 3, we're going to use our passive assessment to figure out some peripheral tissues that may be displaying a protective response. Step 4, we want to find the directions that maybe aren't doing, or maybe parts of the tissue or muscle that aren't doing a great job, so that we can then give the nerve system back the confidence to produce force and have improved movement variability through the whole limb, rather than excessively maybe loading one part, one joint, or one direction. Okay, and then Obviously, at the end of that process, of the end of the first 4 steps, then we have our 80-20 rule, where 20% of our time is going to be focusing on the symptoms and 80% of our time is going to be actually addressing the true stressor. Okay, that's going to allow us then step 5, component 5, to effectively explain the problem and the solution to the patient. To describe the solution, then what we're going to need here then is we're going to need to understand steps 6, 7, 8, 9, 10, 11 and 12, which we're going to cover on the next episode, where we start to go into how we would start the treatment plan and take that patient from the bed and progress them through a graded exposure program, very logically specific to that person, to help them get that meaningful impact, to help them get the outcome that they want. Okay, so that's it for today. Again, please don't be afraid to look at the accompanying blog, where you'll see an extended article on the 12-step successful discharge that I use, which is a key component of phase 1. And once we nail phase 1 and we have the confidence and clarity on the problem and the solution, then I see a lot of other stuff, a lot of problems, even problems within your private practice start to resolve themselves. So hope you enjoyed today's show. Please visit www.thegotofysio.com, where you can check out the blog, you can check out my Go-To Physio show, there's links for that. You've got my 6-step patient adherence checklist. That you're doing all these things to make sure you have adherence, which again, in the coming episodes, we're going to dive deep into that as a standalone episode. You can also download other clinical content to help you develop that step-by-step system. And then you also have an opportunity to pick up my book as well, the Go-To Physio, which that book goes in depth into these 12 steps as well. So if you want to pick up that book while stocks last, we have some accompanying DVDs to go with it as well, to help you implement it even further in the real world. So that's it for today. Thank you for joining me. I appreciate your attention. I'd love your feedback. Please don't be afraid to email me with comments, good or bad. As I said, this podcast, it's there to help you implement this content in the real world. And hopefully there's a couple of things today that I've said that maybe is just going to trigger you to help in the real world. Now, the beauty of our profession is this is just one way to look at the body. I'm not for 1 minute saying that this is the only way to do things, but this is the way that's been successful for me in both professional sport and private practice. So once again, thank you for your attention, and I'll see you on the next episode. Hey, I hope you enjoyed today's show. For more information, please visit www.thegotofysio.com, where you can download my 6-step patient adherence checklist absolutely free, as well as read the accompanying blog that goes with today's episode. We've got lots of cheat sheets and clinical content to help you implement to get real world results with real patients, that ultimately helps you become the go-to therapist and allows you to build a profitable, busy private practice, or become that go-to therapist in professional sport. I'll speak to you soon on the next episode.